let's move on because we have one more talk, which I think is really important and relatively novel, which is about ophthalmic artery Doppler. So Thomas Hanton, who is obstetrician and gynecologist, he is our clinical research fellow. He works at St. George's Hospital, and he's doing his PhD on maternal cardiovascular assessment, including ophthalmic artery Doppler. So he measures many patients for ophthalmic artery Doppler.
Perfect. Thank you very much for the invitation to speak. And I hope to share a little bit about ophthalmic artery Doppler, both why we do it and also exactly how to measure it, because I think a lot of people in this audience will be sort of much more familiar with fetal scans, but this is a maternal scan, so looking at the maternal background. I'll just quickly go into a little bit of an introduction about preeclampsia, which is sort of the main reason why we are looking at the ophthalmic artery Doppler. So obviously, globally, preeclampsia has a huge sort of global burden on maternal health. So 3 to 5% of all pregnancies are affected by preeclampsia, and it causes a very significant number of maternal deaths. So 16% are due to hypertensive disorders. The World Health Organization in 2023 said that 42,000 maternal deaths are as a consequence of hypertensive disorders in pregnancy. And it leads to maternal complications and perinatal complications. So the maternal complications are things like eclampsia, problems with kidney failure, kidney damage, HELLP syndrome. But also we know that preeclampsia is also linked to an increased risk of cardiovascular disease later in life, so 2 to 3-fold increase in cardiovascular disease. And then it also has all the perinatal complications associated to preterm birth. So because we detect preeclampsia, babies may be delivered earlier and have all the complications of prematurity, and also have a lot of associated effects as a result of being small from placental dysfunction. So just a little bit on the pathophysiology. It is quite complicated, the pathophysiology of preeclampsia, and it's definitely evolved recently. But things like maternal factors are definitely a more important and more established background risk for preeclampsia. So things like hypertension and generally cardiovascular sort of problems, and that can lead to abnormal placentation. There are also problems with placentation that can be caused not from maternal factors, and also from sort of increased demand, so things like multiple pregnancy and big babies. And all these things can lead to placental hypoxia and result in sort of angiogenic shifts and systemic endothelial dysfunction, which results in lots of the consequences of preeclampsia. So how do we screen for preeclampsia? So this is where I'm coming to with the ophthalmic artery, so bear with me. At the moment, in the UK, most hospitals screen based on sort of NICE screening criteria, which detects about 40% of preterm preeclampsia. That looks at 10 risk factors. The Fetal Medicine Foundation has published a multi-marker competing risks model, which has a higher detection rate for preeclampsia, and that incorporates not only those background factors, but also some measurements, so looking at mean arterial pressure, so blood pressures, uterine artery Dopplers, and then some biochemical markers. At the moment in the UK, the National Screening Committee doesn't recommend population-based screening, and that's partly because some of these screening sort of methods are expensive, and they are not necessarily sort of well established, and we don't necessarily have the sonographers who are able to do all of these measurements in these particular ways. But it's important to do screening because sort of from the Asprey trial, sort of it's clear that aspirin at 150 milligrams a day for patients who are screened in the FMF algorithm can reduce the incidence of preterm preeclampsia. So the ophthalmic artery Doppler. So the ophthalmic artery is a blood vessel that is one of the first branches of the internal carotid artery. Now, it gives us lots of insights into the maternal cerebral um, circulation, and it has a very distinctive waveform. So it has these distinctive peaks, so PSV1 and PSV2. So these peaks are essentially pressure increases within the blood vessel sitting behind the eye. So that first peak is caused following cardiac contraction and ejection of blood into the cerebral circulation. The second peak, which you can see in orange here, is as a result of peripheral vascular resistance. So when the heart contracts, it causes a rebound effect off the peripheries. So when the blood gets ejected into the aorta and into the sort of legs, it will hit smaller blood vessels, and it will cause that pressure to rebound back up to the heart and then up into the cranial circulation. So in some ways, this first peak gives us a little bit of an idea about sort of cardiac output. It's not a direct measure of cardiac output, but it's sort of correlated to it. And the second peak is more a sort of resistance sort of measurement. And we tend to look at a ratio of these, but I'll go into it. So in terms of how to measure the ophthalmic artery, so the key things are having a high frequency linear array and then setting it up correctly on your machine. So unlike a lot of the obstetric talks we've just heard, where sort of the setup is very straightforward because it's often what's done routinely, this often has to be done sort of customized a little bit. If you do have an ophthalmic artery preset on your machine, it makes it a lot easier. But most machines will just have a vascular preset, and then you may have to adjust some of the details within your machine settings. So that's, for example, making sure your depth is optimized. So we've already had sort of mentions of how to make sure your images are very high quality. So having a relatively short image depth means that the quality of those images of the ophthalmic artery will be improved. And then making sure that focus is around where the ophthalmic artery sits, at about 3 to 4 centimeters. When you use your pulse wave velocity, you want to make sure your sample gate is 2 millimeters. You can angle correct, because when you're measuring velocities, you want to be as straight on as possible. But you can angle correct up to about 20 degrees. And again, I'll go into a little bit more detail and show you some examples. And then wall filter, so that reduces artifact. PRF at 20 to 40 centimeters per second, fast sweep speeds, and then again, I'll discuss some of the safety parameters. So what you want to do is make sure that your patient is well positioned. So you want to have them supine or semi-recumbent. Ideally, you'd want them to rest for 5 minutes prior to measurement. Sometimes the optimal way to do this is if you were doing it as part of another scan, you just do the ophthalmic artery towards the end of the scan. Another key part is making sure your patient understands what you are going to be doing. So essentially, it's placing a probe on the eyelid with a very small amount of jelly on it, and it's on a closed eyelid. I think a lot of patients get a little bit anxious about having a probe on their eye, which is not the case. It's very much just on the eyelid, and the jelly doesn't tend to get into the eye at all. It just sits on the eyelid. The other thing is just explaining that there's not going to be a lot of pressure, because you do actually want to minimize pressure when you're placing a probe on the eyelid. So just a couple of very short clips to show you just what you'd be scanning through. So this is just scanning up and down through the eye. And what you can see in the middle of this image is the optic nerve, which appears as a hypoechoic band. And then sort of you would scan just superior to the optic nerve, and then you'll identify the ophthalmic artery pulsating just superior and medial to it. Now you can see this ophthalmic artery in this image. It doesn't come directly perpendicular towards the probe, although sort of a part of it does come a little bit closer. So you probably, with this particular image, would want to sample it sort of in the straighter portion, so that your angle correction is going to be sort of less than 20 degrees, because at that bottom part, you're going to introduce a lot of error as a result of angle correction. The other way you could do it is you could move your probe a little bit to try and straighten out that vessel. So this is sort of what the waveform would look like once you've captured it. So again, on that same image, you'll get a series of traces. Now it's important to make sure that your waveforms look similar. So you want to be not just capturing one or two, you want to be capturing a series of sort of 4 or 5 waveforms, so to make sure you've got representative images of the waveform and ensure that you have the correct vessel. It is, on modern ultrasound machines, very easy to capture the wrong vessel. Sort of sometimes you can place the gate over sort of what you might think is the ophthalmic artery, but it's actually a branch of the ophthalmic artery. It is sort of very easy to do. There are sort of a few techniques that I'll sort of briefly touch on in a moment to make sure you've definitely got the right vessel. So just to go over the waveform itself. So as I mentioned before, you've got that first systolic peak. So that corresponds to sort of that initial cardiac output driven peak. Then you have the second systolic peak, which is that just notch just next to it. You have the end diastolic flow, which is sort of right at the end of the waveform, and that's basically the baseline flow through that vessel, so maintaining that blood flow going forward. And then you've got a few calculated markers. So this is the same as all Doppler waveforms. You'll have your resistance index and your pulsatility index that can be just calculated through these formulas. The key calculated marker is actually that's been published on significantly in relation to preeclampsia is looking at peak systolic ratio. So that is PSV2 divided by PSV1. And here's a trace adapted from Kasuma et al.'s paper in 2025, which shows the changes across gestation of the peak systolic ratio. And it's interesting to show that it doesn't actually change that much in terms of total PSV ratio across gestation. Obviously, there is a dip in the mid trimester, and it does increase towards the end. So it's actually quite similar to a blood pressure profile across gestation. So just to recap all of those steps. So step 1, make sure your patient is correctly positioned and introduce the probe onto the eyelid. Step 2, identify the optic nerve. Step 3, apply color Doppler, hand superior and medial to the optic nerve to identify the ophthalmic artery. Position the pulse wave Doppler sample gate over the ophthalmic artery. Optimize the angle of inclination so that you don't have any errors as a result of that. Acquire your waveforms, measure your Doppler indices, and make sure you measure both eyes. Now, I'd also recommend you measure a couple of sets of waveforms on each eye as well. Now, just to go back to what I mentioned before about sort of identifying the ophthalmic artery. So one way to be absolutely sure is sometimes it is quite sort of medial. So it can be sort of hard to identify if your angle isn't quite right on the eye. Sometimes you can get the patient to look medially, and that can help you identify the ophthalmic artery. Now, it's best not to measure the ophthalmic artery when it's in that position, but it does help you visualize it and know where you should be looking. So that's sometimes a little bit of a tip to be able to help you find the ophthalmic artery. Safety considerations. So ocular tissue is very sensitive, so it does require some safety parameters to be maintained. Now, on ophthalmic artery presets, that will normally be preset by the machine, but the BMUS guidelines are to have a mechanical index of less than 0.23 and to have a thermal index of less than 1 to prevent thermal tissue effects and acoustic cavitation. Now, with the eye tissue, that would be pretty problematic if you were to cause mechanical cavitation within the eye. And of course, the ALARA principle should always be maintained, so as low as reasonably achievable. So trying to minimize your power, minimize all of your sort of time to capture the ophthalmic artery traces. So what's the evidence? So in there's a few big screening studies, so particularly looking at this in a screening context that have come out of King's. So Ganna et al. In 2022 published on looking at the ophthalmic artery in the first trimester. In terms of the addition of ophthalmic artery Doppler, it did improve detection rates, but only by 2 to 3%. So, and particularly only really for preterm preeclampsia. In terms of our term preeclampsia detection, I mean, even other markers are pretty poor at detecting term preeclampsia, and that's still a problem, still something that there's a lot of research going into. But in terms of preterm preeclampsia, it definitely improves the detection, but sort of not by orders of magnitude. But actually, our detection rate is pretty good, sort of using these kinds of screening methods. In the second trimester, I've just highlighted a couple of rows for sort of if you were offering screening sort of with generally more cost-effective methods. You increase the detection rate from 72.2% to 88.9%. So a more substantial increase in detection rate, and that's with a 10% false positive rate. And then in term preeclampsia, again, there is a small increase in detection rate with the ophthalmic artery Doppler, but again, our detection rate is pretty poor for term preeclampsia. So beyond preeclampsia prediction and screening, what else could we use it for? Well, these are still areas which are being researched and sort of expanded out to, but sort of within disease stratification, working out which patients might have more severe preeclampsia versus less severe preeclampsia. If we're seeing an effect difference between preterm preeclampsia and term preeclampsia, perhaps the ophthalmic artery Doppler could shed some insights into that. And then low resource settings. So although ultrasound is something that a lot of people don't have access to, it is potentially a one-off cost, something that you just need to have access to a probe and a machine, and sort of actually more and more handheld probes have the capacity to measure ophthalmic artery Doppler. So this really has the potential to replace biomarkers for low resource settings. And actually you saw in those numbers from the first and second trimester screening that actually it has a similar ability to sort of differentiate as SFLIT and PLGF. And then the other sort of aspect would also be postnatal monitoring. So potentially we could use ophthalmic artery Doppler to monitor patients who've had preeclampsia and see how their progression trends. So overall, I hope that I've given you a bit of a whistle-stop tour on how to obtain ophthalmic artery Doppler. It's very easy to obtain measurement. I've given you the 9-step process to do so, and I hope that you can take that away and practice. The ophthalmic artery Doppler, I think, has fantastic insights into maternal cerebral hemodynamics, which hopefully can inform us more about preeclampsia. And I think there's a big growing body of evidence on how useful it can be. And it's such an easy measurement to do that I think we should be integrating a lot more. Thank you for your time.
Thank you very much. Thanks, Thomas. And thank you for sharing stuff with the actually the background and also the technical aspects, and particularly the specificity, like the specific setup for the machine. Certainly I'd like maybe to invite the speakers. I'm conscious of the time because obviously this webinars we try not to go over 2 hours, but today, because we had four talks, certainly we did exceed 2 hours. And I always say it's not healthy to be in front of the computer for more than 2 hours. But I think it will be really important to have a short discussion, and just before we close. But there are lots of questions. I've been through all of your questions and comments, and I summarize sort of the themes. Jadar has daddy duties, so unfortunately he had to go. I'm not sure that he's able to join the discussion. But if I start with you, Thomas, the last talk. So there's some question about, can we use curvilinear probe? Does it have to be linear probe? Because linear probe is not commonly used by obstetricians.
Yeah, so I think this is something that we've been looking at St George's. It seems we've measured multiple patients with both linear and curved probes. It definitely gives you a worse image quality to measure it with a curved probe because it's not set up quite as well. But actually, the numbers that we get from our measurements are very similar. So we do see that so the curved probe, and the reason we wanted to look at it was because we know that obstetricians have curved probes and don't have linear probes, and it's a lot of extra effort to have to go and sort of source linear probes. So I think that it's definitely possible. It's not quite as easy to measure, and you don't get quite such clear images of the eye. So yeah, there's a bit of a balance with that.
Yeah. And of course, the linear probe is a lot smaller. So if you have the space, when you have sort of the curved linear, tend to be a bit bigger, I think, for the space. Um, in terms of the people asking about the reference chart or the ranges of PI and RI, and as Thomas mentioned, is when you do the ophthalmic artery Doppler, the RI and PI is not really the parameters that have shown to be demonstrated to be clinically useful. It's more about the peak systolic velocity and the ratio. There's a question about, can you have the second higher than the first? So if you look at the shape of the waveform, is the peak, the first peak is higher than the second peak. Can you have any situation where you can have the second one higher than the first?
I personally haven't seen it higher in the second than the first, and I can't imagine a situation where that would be possible. The only thing is elasticity of blood vessels can sometimes give you slightly unusual readings. So sometimes if something sort of is held in a sort of elastic recoil of a vessel, it can sometimes give you funny readings, but it's not something I've seen.
Okay, lovely. So Shriyazi, beautiful talk. Some questions about from people. How do you determine right and left in the fetus? So if you just take systematically, sort of how when you start scanning a fetus, how do you do it? How do you determine right and left, transabdominally and transvaginally?
So, this is a very commonly asked question, and there are multiple ways described in literature.